Hi there, I'm Dr. Helen Sue, and welcome back for part 2 of the Ancestors to Influencers talk about Asian American mental health. And I've broken this up into sections so that you're not stuck here for a more than hour-long presentation, but this was an overview of Asian American mental health as invited. Thank you to AAPI'S, the Asian Pacific American Medical Student Association. Now, where the last part of my talk left off was really talking about how little funding there has been for Asian American, Native Hawaiian, Pacific Islander research. And so we get stuck in that cycle that we have very little methodologies and research for our communities, but then there's no funding to create it, and so we're in this cycle. But today I want to talk about some of what we do have. And we do know that Asian American mental health needs are different. We have very non-existent or poor quality data, but that is slowly improving with each generation of researchers. There's language access issues and challenges. How do you provide services and good quality information and have providers for a population and community like us that has dozens of languages? Do we have culturally responsive providers who actually even practice with humility and have the slightest degree of knowledge or respect for the health norms, the cultural norms in our families? So core value differences, what is the very goal, for example, of mental health treatment? Is it independence? Is it independent living? Is it working? Is it health? So very different values, sometimes underlying treatment. Culturally skilled providers, do they have any experience serving diverse communities? And specific population needs and features. So for example, there are very specific needs in some of our communities because of refugee trauma or immigration trauma or racial trauma that they may have experienced or identity issues depending on where they're living. And does someone have skills about that and understanding spiritual communities and practices, all of that. Now these pictures here, we're going a little bit back retro. 1972, WAIANAE Health Center in Hawaii, their first employees, this small group here, and this larger picture, Asian Community Mental Health Services, also in the early to mid 70s. This is how these agencies began. Very grassroots, small group of people in the community who realized, hey, we have needs in our community for Asian American mental health, and no one's really providing it or skilled, but we can apply for some funding from the county, really try to recruit our own providers and build this thing. And so that was how some of these agencies began. And what does Asian American Pacific Islander mental health access even look like right now? Just a general picture. So for example, I took a few snapshots from Alameda County Behavioral Health Care Services, so where I spent much of my career, and Los Angeles County data. So for example, in Alameda County, you have 6 million Asian American, Native Hawaiian, Pacific Islander people in the community who are eligible or who live in the county. It's a really big county, as you can imagine. And of those eligible, and so this is a Medi-Cal county mental health system, but out of those eligible, only 2% actually utilize the mental health care system. 2% out of all of the county people who are eligible. So clearly we're not reaching people who could have need. The usual average is to say that I believe the goal is that we would like to reach a minimum of 8% of eligible of the community, and here we are at 2. In LA County, 22% of AAPI'S have no regular source of any medical care, mental or physical, and they have the highest rate of uninsured after Latinx communities. So 1 in 5 are uninsured. In the national data, it's not because we have less need. We have a 17.3% lifetime rate of psychiatric disorder, much like many other communities. Over an average year, a little more than 9% of us will have a mental health psychiatric disorder. And yet, we are 3 times less likely to seek services compared with the white Caucasian community. And even when we do seek services, can we find somebody who has the cultural humility skills? So we have huge access issues at multiple points, even having insurance, getting in, finding the right provider, and our own willingness to beat back stigma and seek help or know how to find it. How do these health disparities actually impact our communities? 1 in 2 Asian Americans can't find mental health services that meet their language needs. There have been studies finding that the risks do vary within the largest 6 Asian American ethnic groups studied. So for example, Cambodian Americans in the US have 7 times the rate of depression and 15 times the rate of PTSD than the standard US population. CDC studies have found that the Northern California youth suicide rate was 4 times the national average, and many of those students were AAPI or mixed race Asian Americans. And there's been studies that more than 10% of AAPI students had thought about suicide, had suicidal ideation, compared to 9.5% of white students. And so this is a snapshot of how we're doing and how does these health disparities and mental health issues impact our communities in various ways. And what do these barriers look like? So to not be too abstract, these are really brief system of care examples. These are all, of course, client vignette pseudonyms to protect patient confidentiality, but real situations. Sakam is suffering from depression and addiction and drops out of school. He is the sole Asian client in his rehabilitation program, feels unsafe and unwelcome, and ultimately dropped out. Prasanna's white therapist advises him to cut ties with his South Asian family because, quote, they have such unhealthy boundaries. Kiet feels insulted by a social worker who seems stunned to hear that gay Asians exist and assumes that he is an English language learner and a refugee, when Kiet is actually a literature major born to a doctor and an engineer in Sacramento, so racial stereotyping, even from a professional. Marianne worked abroad for 18 years to send money home to her children in Indonesia. Her daughter's therapist said theirs was not a normal or real family and assumed they could not benefit from family therapy. So again, a therapist who doesn't know really anything about how common it is in many home countries to have to work abroad in order to care for your family, and that there's many ways that a family can be normal or show their love and care. And I'm not in meds, but a brief bit about psychiatry in Asian Americans. And these are some of the local psychiatrists that we have in my area that are named in our resources list. But when AAPIs get to therapy, we tend to have higher severity of illness at intake because we have tended to wait a long time before coming in. There is a pattern of medication compliance issues, not taking it as prescribed, not being happy with the prescription, not having communication with the doctor. And more importantly, we're really understanding that there's variable psychopharmacokinetic and pharmacodynamic profiles of these medications. What does that all mean? Those are really long words that really talk about dosage and side effect profiles we realize now affect people really differently. Some of you may know this about yourselves. I know that when I take medications, the dosage that they have for a standard, weird, probably medication tested on a white adult male, those dosages don't work well for me and tend to make me feel pretty bad and have bad side effects. So dosage and side effect profiles we are starting to realize are different for different communities. So there's a whole field of ethnopsychopharmacology that actually looks at genes and culture and environment and how that might affect how a psychiatrist can best serve you. And Samuel at UCLA does a lot of work on that, and you can read more about this sort of growing new field that realizing how do we tailor psychiatry to better fit AAPI populations. Just talking about organizations, the Asian American Psychological Association, I'm very proud to say I am a past president. It was founded in California in 1972 to advance the psychological well-being of Asian American communities through professional practice, research, and teaching. I would say a lot of it now too is about mentoring, that we have a lot of up and coming AAPI clinicians and researchers, that the majority of our membership are grad students and young. Is multidisciplinary, so although founded by psychologists, it's also open to all others in affiliated fields, whether it's sociology, counseling, Asian American studies. We've had health, nursing professionals, anyone who cares about psychological well-being of Asian American communities. And that's Dr. Gerald Wing Su, who was my professor at CSBP when he was in California and was the first president of AAPA. And if you want to read more about cultural responsive work, definitely look up Gerald's work. AAP also publishes the AAJP, the Asian American Journal of Psychology. So I found that people often have questions about, has anyone ever done any research about, for example, what is this thing called tiger parenting? Is that even a real thing? There was a special issue on that. What are issues about identity development or gender or various mental health topics? AAJP aims to promote better understanding of Asian American individuals and communities through research, practice, advocacy, education, policy. So it's a great journal. You can find it access online, as well as it's included in AAPA membership. And over the years, who we are as AAPA has continued to evolve. This is one of the more recent, I believe it was 2018, past president gatherings. And you can see that there's more intergroup diversity now, that while we had started as an organization founded by East Asian, heterosexual, academic men, many US born, our presidents and our membership now are very, very diverse. We are growing and we have divisions focused on women, on South Asians, on students, on Filipinx communities, LGBTQ topics, multiple heritages, clinical practice, and an education and training committee. So these are all aspects now of Asian American psychology where there's a lot of growth and new leadership coming. And perhaps the best example of that is the AAPI Mental Health Leadership Development, that we've had leadership fellows for early career professionals, and now we've also had Leadership Institute retreats, 2 so far, and hoping to have another in the following year when we return perhaps to a non-pandemic convention. But we're really seeking to cultivate cultural expertise from those who share values and life experiences with the communities that they're actually serving. So really knowing that the expertise and wisdom that comes from within communities is our best shot at integrating what we know and bring in terms of cultural strengths with what psychological practice and training might bring us to bring that to contemporary needs and challenges. And we talked about ancestors and influencers, that social media, for example, despite its many challenges, has been a wonderful tool to bring Asian American mental health dialogue, stigma busting, knowledge to communities that was not previously available. So, for example, the Subtle Asian Mental Health Facebook group passed 45,000 members in approximately 2 years. There's Dr. Rona Hu at Stanford Psychiatry and myself were consultants on a Netflix show. Dr. Ramani on the Red Table Talk, Dr. Kevin Nadal in many modalities, the Psych Show with Dr. Ali Matu, Emily, that you'll also see listed in the resources at the end as a mental health advocate with lived wisdom, that social media provides avenues for influencers in education that is beyond just the clinical and professional realm. That AAPI mental health is moving into the mainstream. It's a very powerful thing when famous and successful people like Tess Paras or David Chang talk about Asians do therapy. Asians have mental health needs and growth and vulnerabilities, and we should share these kind of stories, that we're not a monolithic group and it's not a monolithic thing, but how do we actually work to make our communities more aware about mental health, to fight stigma, and to bring better care? Instagram's been a great resource for many voices who traditionally weren't able to get their messages out, their stories out. Cross-pollinating with our friends in other communities, Black, Indigenous, people of color, queer communities as well. How do we understand Asian American life, including our mental health, and maintain that? And I include the Melana Mental Health Instagram post that is absolutely one of my favorites that addresses intergenerational healing, which is something a lot of AAPIs, especially from immigrant and refugee families, feel is something very pertinent they bring into the therapy room much of the time. It's important to think about who we are too. Are we digital immigrants or are we digital natives? That so many of our current influencers, iGen, younger generation, are what we'd call digital natives, meaning they were born into a world and a time that they've never not known technology, smartphones, social media, whereas many others, myself included, are digital immigrants, and some of us more recent and others have been involved further back. And so that has an impact on how well we know how to use and access online and text-based information, support, process groups to actually do things like training and supervision, or actually seek mental health services. So even, for example, this is Farhugs. It's an online therapy format that's available in Taiwan. And so really thinking about how mental health practice is changing based on your digital comfort and skills. And now, which was not the case when I made the presentation, but now with pandemic, COVID-19, how we are all adapting and having to grow telehealth and training to be done in these remote formats. There's a lot of AAPI content creators now, representation, more from men, talking about mental health. You can look at, there was a short film, Gordon Yao, that was lovely and bilingual. And there's leaders, Asian American women, talking to normalize mental health treatment. Again, you can look up all of these resources later. But just examples that there are a lot of people working to fight generations of stigma about what mental health is and is not, what treatment is and is not. Culturally responsive initiatives locally. So just some examples of what does this actually look like. So Asian Pacific Family Center in Rosemead has a multilingual team. It's where I had actually been privileged enough to do my pre-doctoral internship training. And that's a community mental health clinic with the skilled and multilingual staff to serve the surrounding community in an adaptive, culturally responsive way. LA County has a cultural competency unit. In San Mateo County, they call it the Office of Diversity and Equity, and there's 8 different health equity initiatives. San Francisco County has Office of Equity, Social Justice, and Multicultural Education, formerly known as Cultural Competence, but now we realize we never really achieve competence. It's sort of an ongoing thing for everyone. And Alameda County has a Cultural Competency / Ethnic Services focus. So these are how some counties are really trying to bring in more culturally responsive initiatives for AAPIs and other groups as well. And I do want to call out, though, what is our role as a community and what do we prioritize? Because one thing that's been very disheartening and due to stigma, I think, and maybe misplaced priorities is these are photos from school district meetings in my local area where Asian American parents have organized themselves to fight for things like more academics, less sexual education, wanting a pool. And while those are not bad things to want, it pains me greatly that we'll organize for that, but not for more mental health education, not for more mental health counselors. Because over and over we've seen that, you know, shielding your kids from sex ed or getting them into more AP classes or more athletics doesn't protect them from suicidal ideation, from bullying, from identity issues, from anxiety disorders. And so we as a community need to really think about long-term, what are we prioritizing? Just because our kid has good athletics or good grades does not mean that they are mentally healthy. And for AAPI mental health professionals, we have our own challenges. These are some of my colleagues from Asian Community Mental Health Services. We had a reunion. Some of the most giving people I've ever had the privilege to know and work with. And it's difficult work. There are ethical concerns. How do you draw community and personal boundaries when you may be coming from a small community and you need boundaries around what's the work you do professionally and what you do with your own life and family. There's vicarious trauma. That's a whole talk in itself. How is it to do work when you're constantly being exposed to others' trauma, especially if you're serving a community that's really experienced very high levels of trauma, such as ACMHS. We served a lot of survivors and refugees that had come from Laos or Cambodia. So vicarious trauma, we're often under-resourced. We don't have the funding or the investment of major donors. We have to fight to get funding from counties and insurers that we're often not seen as a community that needs a lot of help. And so we have to really work and fight and advocate to get funding. There's a lack of mentorship and supervision. Because there are so few mental health professionals who are AAPI, how do you find the right clinical supervisor and professor and mentors to teach you how to do this? Training programs tend to be inadequate. Maybe you get one class on multicultural clinical skills. Maybe you get another one on a specific population, but it's not required. And so often training programs themselves are inadequate in preparing someone to work and serve with AAPI communities. Even if you are Asian American yourself, doesn't mean I know all the skills about all the different communities, and I needed training and a lot of supervision. The work environments tend to be extremely high stressed, and burnout is a real issue that a lot of community-based agencies like ACMHS, APFC that have appeared in this slideshow have really high levels of staff turnover just due to burnout because there is so much need and so much work with low resources. And as we get closer to the end of this segment, I want you to think about policies, that policies impact AAPI mental health access too. So for example, in the state of California in 2004, we passed Prop 63. I remember going around and getting signatures at parties, asking people to please put this on the ballot so that voters could vote. And it was passed. And it just said that for people earning over $1 million, that a tiny tax would be levied, and that money would be dedicated to mental health. It is now a huge percentage of the entire public mental health budget, as you can see. And there's things written into the policy of what happens with Prop 63 money. And so it has to emphasize things like being consumer driven. It's funded consumer and family and caregivers to be a part of planning what is needed. Integrated service models driven on resilience and recovery, cultural competence and collaboration. So this was something that made lasting change in a way that maybe sometimes a small grant or specific project would be very beneficial, but wouldn't really make lasting impact. So policy is really important also into best serving the needs of our communities. Community education is always so important. So whether they're public service announcements, presentations, online, in-person at conferences, how do we educate people, right? Asian American high school students having high risks for suicide. We need that information to be out there for families and students and educators and communities to even know what it is what are the services we need, and to also see and know in the Stop Stigma Sacramento campaign, for example, that people can live with something like post-traumatic stress disorder or any other disorder and still recover. That's an important message too. Another example of how this can work in an integrated fashion is just on my campus at Stanford, that the Counseling and Psychological Services Center partners with community centers. So we try to support students in their activism, relationship build beyond NSO, so new student orientation. Yes, we're there to welcome new students, but also to be there as the year goes on, stresses builds up. Offering drop-in community connects office hours. Someone may not feel comfortable coming to the counseling center yet. They can just drop in and ask a question or get a resource. Clinical consultations. We teach a workshop, Decolonizing Mental Health, which is really tailored for BIPOC communities. And we teach once a year a wellness course dedicated to Asian Americans, Pacific Islanders, and talking about mental health. And so these are all ways of bringing mental health outside of a clinical setting, outside of the office. So there's Asian American clinicians, there's focused programming, you can see some of the specific topics, finding community among queer and API grad students. It's a non-clinical setting and it's flexible hours. Sometimes the best time to meet people is in the evening after classes, for example. Or this year I think we're doing orientation on a Saturday. So really getting in the outreach model of getting outside of offices, that mental health resources are for everybody. And ideally, we'd like people to access them before there's a problem, not needing to wait until you're clinically diagnosable, which could take years. And why not sort of address and get skills early on? Another absolutely fabulous example of focused programming is Epiphany. And my colleague Coco Nishi at San Diego, it's a beautiful example of just non-clinical gatherings, and I'm very jealous they have boba breakdowns as well, where people can come and gather and talk about serious issues that may be on their mind as a community, and promote community building and relevant to mental health, like understanding intergenerational trauma, and do it together. That for some of us, culturally, community healing makes much more sense than a clinical setting, or we use both. Stanford CHIPAO is another I would really recommend, that was started by psychiatrists at Stanford and is a communication health interactive for parents of adolescents and others. So if you look them up online on YouTube, they have videos really trying to teach parents, how do we have these really difficult, sometimes frightening talks about something like self-harm or depression, or the bicultural barriers that we have as parents in the AAPI community. So Stanford CHIPAO is another very innovative community outreach project that came out from Stanford psychiatrists, but really went out in the community to respond to especially to the losses that we have had in our local community here, losses and deaths to suicide of young people, that the community was really asking, how can we improve how we are communicating and supporting youth? And this was a great project, so check out Stanford CHIPAO. Bridges to Behavioral Health in the city of Fremont is another program example. They do fun community building things like an art contest. Well, as you can see here is the mayor of Fremont, California, Lily May, with Joyce Slim, a clinical supervisor and one of our art contest winners. But Bridges to Behavioral Health created targeted supports, information, community building, education for primarily Chinese-speaking community, because it's a very big part of Fremont community. Public service announcement videos, brochures explaining what is anxiety, what is counseling, parent education workshops in community settings. We really found that more parents would come to those workshops if they were, for example, taking place at Chinese school rather than them coming to a clinic. And art contests, and they have an Instagram account, Fremont Youth Wellness. So these are just different examples of culturally adaptive programs. SAMHSA, Substance Abuse Mental Health Services Administration, also has multilingual educational and public service announcement materials that you can find online as well. So these are some of our federal materials that you can see here. Although I'll tell you honestly, if you look it up, the government of Australia does an even better job than we do in the US of having multilingual mental health psychoeducational materials, and you can check those out, and those are all free and available. And the final slide for today is another example of a comprehensive health center that I had the privilege to go visit when we did a site visit with the Minority Fellowship Program. That whenever I get pushback, usually from the powers that be, about, well, how do you integrate culture into modern Western healthcare? Like, that seems really difficult, or that doesn't seem like it could be done realistically. I point them to this perfect example, that this was a grassroots agency started by the community that has now grown to provide behavioral health care, mental health, emergency services, medical care, but integrates traditional Hawaiian healing, has a Kapuna council, so a council of elders to inform that what they're doing is culturally appropriate. Healing gardens and paths on the premises. There's an elder day program, and there's school and satellite sites also away from the clinic. And residency and internship sites, positions to train future practitioners in what is a culturally, spiritually grounded way to do excellent holistic healthcare. So I will end this segment of Ancestors to Influencers, the history of Asian American psychology, leaving with these fabulous examples. And there are many, many more growing day by day and year by year, which is wonderful, of what it actually looks like when mental health facilities or education and services integrate culturally responsive components. And next time we'll talk more about how the future of this is all going for Asian American mental health. Thanks so much for watching, and stay tuned for section 3 of Ancestors to Influencers. And we will